What's the function of the kidney? Yeah. What type of waste though? Nitrogenous waste products, right? That includes ammonia, folks. Ammonia is part of that as well. So yeah, nitrogenous waste products, and what else? Salts. Regulation of water fluids, that's right. Yeah, all those elements, folks, make sure you remember those. Also, when it comes to the acid-base balance, what part of the acid-base balance do the kidneys influence? The base? Good. What else is it called? Alkalinity, HCO3. Make sure you folks know that, okay? If your HCO3 goes up, if your kidneys start excreting a lot of bicarb, a lot of base, a lot of alkalinity, what happens to the pH? What goes up? The pH goes up, that's correct. It becomes alkaline, more alkalinic, okay? The acidity goes down. Does that make sense? All right, good. What happens if the kidneys stop functioning? All the toxicities inside the body. What else? What happens to the pH balance? The pH will go down because there's no HCO3. That's correct. All right, good. Where are the kidneys located? Retroperitoneal. Okay, good. What's albumin?
It checks water.
It checks water. Okay, what's albumin? It keeps the water in check, right? It keeps the water in check. It regulates the fluid. So what happens, folks, if I have nephrotic syndrome, meaning my kidneys aren't working, and I'm getting rid of albumin, which is a protein, what happens to the fluid in my body? It goes to the interstitial spaces. You develop edema, or you can develop ascites. It just means that the fluid no longer stays inside the blood vessels where they're supposed to be. They're inside the blood vessels, folks, because where are our cells? Inside the blood vessels, in the blood. So it's the fluid, the water is readily accessible for the cells to just as they need it. So it's got to stay inside the vascular system. That's important. So whenever you have some type of traumatic issue, like a burn, or whenever you have issues with your kidneys, you lose your albumin, your fluid no longer is no longer in check, and therefore it goes to its interstitial properties. Does that make sense? So if somebody does the serum albumin level, okay, your albumin level. There's another element called globulin, folks. It's the same thing though. It's another indicator of protein. What if the globulin albumin ratio is low? What does that mean? Edema. Good. What happens if you have leukocytes in your urine? Infection, blood, RBC's blood. Okay, good. Remember, folks, that when it comes to the skeletal system, the kidneys are responsible for regulating calcium and phosphorus as well. Remember electrolytes? So if the kidneys are damaged and the calcium is elevated in the bloodstream, where is it not? It's not in the bone, so you'll have pathological fractures and all those elements. All right, good. How does your renal system or your kidney system affect the cardiovascular system? Blood pressure, yeah, blood pressure, because again, it regulates the fluid content. If you have a high fluid content, your heart has to pump harder to pass it on through. You folks remember from like A&P, which hormone raises blood pressure? Begins. Which? Renin, yeah, renin. You folks remember renin? The RAA mechanism. Renin is released. Angiotensin 1 becomes angiotensin 2, which means it constricts the blood vessels. And then aldosterone is released. Aldosterone does what? Retains sodium. Good. So now, what happens to your cardiovascular system if you're retaining all the sodium, hence you're retaining what? You're retaining fluid, water, right? So what happens to your blood pressure? How do we know that, hey, that's enough?
Oh, your arterial.
Yeah, atrial natriuretic peptide. You guys remember that?
Yeah.
The AMP, the atrial natriuretic peptide. This is another hormone, folks, that once your atrium of the heart starts pumping too hard, it sends a message to your kidneys, hey, it's too much. Dump out some sodium. And that's how we maintain homeostasis in a way. Does that make sense? All right, good. So aldosterone, atrial natriuretic peptide, These are all elements that function with sodium, right? What does angiotensin function with? Constricting of the constriction of blood vessels. Good. If your kidneys are responsible for base and HCO3, what are your lungs responsible for?
CO2.
CO2, also known as
Acidity.
acidity. Okay, good. Which of those organs, folks, or which of those properties of the structure are responsible for carrying the urine product to the bladder?
Pelvis.
I'm gonna ask it again. Which of those parts is responsible for carrying urine down to the bladder? Ureter, yeah, the ureter. Good. After the urine collects from the collecting ducts, where does it take its urine to? The calyces or the calyx. The pelvis in a way as well, but I'm talking about this portion first. The little cups. The little cups. And eventually, it starts concentrating the urine and it dumps it out. So hence, it goes to the bladder, it gets full, we urinate, all that good stuff. Let me see. What is the functional unit of the kidney? Nephron. Nephron. Does what was that?
I missed my answer.
Oh no, it's okay. It's okay. What happens with age, folks? What happens to our nephrons with age? Yeah, they start dying off. Why? Because all those fun weekends that you guys had. Eventually, little by little, they start being deteriorated. Yeah, that's right. All right. Real quick, guys. What hormone acts on this part of the tubule? Okay. ADH. Aldosterone functions in the distal convoluted tubule. Okay. ADH. Remember, because ADH only has to do with fluid, right? Same thing with mannitol for the osmotic diuretic. What medication acts on the loop of Henle? The loop diuretics, Lasix, loop diuretic. The thiazide, folks, maybe I said something else yesterday. I meant to say that they're both potassium depleting, but they don't both work on the loop of Henle. One of them, Lasix, works on the loop of Henle. The other one works on the distal convoluted tubules. The thiazides.
What are they doing?
The thiazide, the hydrochlorothiazides, the ones that are like the diversion of your Lasix, they work on the distal convoluted tubules. On the proximal end, but either way, on the distal convoluted tubules. I want you guys to know this. Maximum reabsorption, meaning as soon as all the fluid goes to the glomerula, right? It's being filtered. That's the process that actually pushes all those particles out of the blood into the Bowman's capsule, into the nephron. It's filtration, first of all. So you guys have to know that. Filtration is a process. After that, maximum reabsorption is just talking about all the most fluid that's reabsorbed at any given point, and then in the course of the nephron is going to be at the proximal convoluted tubule. Okay, that's the maximum. Afterwards, it either gets dumped out again into the tubule or gets reabsorbed depending on what the body needs. But when it comes to the most amount of reabsorption that occurs at the nephron, it's usually at the proximal convoluted tubule. That make sense? You guys remember the juxtaglomerular apparatus? JGA? Juxtaglomerular apparatus. Anyway, folks, well, the juxtaglomerular apparatus, you can't really see it here, but it's a network of tissue and cells that are responsible for releasing renin. Okay, and it's at the Bowman's capsule. I won't be on the test, but well, it might be. I don't know. I'll give you guys the handout has this, by the way. It helps out a lot, and it's also in your book, by the way. We have 2 ureters, 1 urinary bladder, 1 urethra. Oh, what happens if a male has an enlarged prostate? Yeah, you can't urinate. You can't micturate. That's right. Urinalysis. You folks remember what a urinalysis is?
It's a dime.
Pardon? It's a test, right? It's a urine test. All right, yeah, good, that's right. It's used for a lot of different elements, folks. It's also used to rule out certain things. So if a patient comes in and they have some type of infection and you know it's probably on the toe or something, sometimes the doctor will request a UA, urinalysis, culture and sensitivity, for the simple fact that he wants to rule out that it's not a UTI, especially for the elderly population. The older adult, they'll always want to do a UA to make sure there's no type of UTI. If I tell you the patient's BUN is elevated, what's that most likely an indication of? Dehydration. I have to add the creatinine with it, or the creatinine by itself. Okay? What if I tell you a patient has an elevated creatinine level? That's usually more better indicator that there's some type of renal failure. What's a GFR? Glomerular filtration rate. Yeah, that's right. Essentially, folks, it's letting you know how many elements are being filtered for every minute. It's supposed to be between 90 and 120. That's what I said right there, folks. It can be from like 100 to 125. It just give or take 5 of those. The 90 to 120, give or take 5. That's the average level. A creatinine clearance is letting us know how much creatinine we're getting rid of in a 24-hour period. How do we assess a 24-hour urine specimen? How do we obtain it? After the first void, meaning the doctor orders it now, okay, you void, and then you discard that. You just flush it down the toilet, the next one you collect. Okay, for 24 hours, what happens to the last one? You keep that one. All right. You folks remember what I talked about when it comes to osmolality? Yeah, the particles. That's correct. Yeah. So if I'm dehydrated, is my serum osmolality high or low?
High.
It's high. Osmolality, folks, equals particles. Just think of it like that. Osmolality equals particles. So the particles are high because if I'm dehydrated, I don't have fluids inside of me. So the particles are high compared to the fluid that I have in my body. That's dehydration, right? What if I say that I have diabetes insipidus, knowing that I keep urinating, right? I keep urinating. What's the urine like? Diluted. What's my urine specific gravity? It's going to be very low. Specific gravity, folks, particles, same thing. The specific gravity is going to be low because I'm peeing so much and all the water is diluting the actual particles inside. Good. Anytime you do an IVP, an intravenous pyelogram, what do you assess for? Always for allergy, that's right. Always for allergy. I spoke about the cystoscopy, right? You report any bleeding after 24 hours. And again, the cystoscopy is when you get a camera, it's very thin, thinner than a pencil, and you put it inside the meatus. And it's a scope, and they can actually look inside the structure, see what's going on. You go inside, you're going to cause some trauma. So it's very common to, after you pull it out, within the next 24 hours, folks, it's normal to see a little bit of bleeding. But after those 24 hours, you want to report it because that might be something abnormal. Does that make sense? All right, we spoke about thiazide, loops, potassium sparing, all that good stuff. You have this slide on your packet that I gave you. What's the Coué catheter for? Of the prostate gland, that's correct. So yeah, the prostate gland is pretty thick. It's constricting the urethra. You put this one inside, and they'll actually bypass it. Okay, it'll actually bypass it. If a patient has a suprapubic catheter, what are they at risk for? Infection. It's going to be infection. Remember this, folks. Anytime a patient has a procedure that's invasive, meaning either they're going inside or a surgical procedure like they're cutting you up, for the first 24 hours, you're looking for bleeding. Not that you're looking for, but the most common elements that the patient might be affected by is bleeding for the first 24 hours because bleeding is the first thing that happens, right? After 24 hours, what are we looking for? Infection. Please keep that in mind, folks. First 24 hours, bleeding for any type of procedure. That's invasive. Post 24 hours, infection. Spoke about the condom catheters. Don't put tape on it. Remember that? All right. This is not on your PowerPoint, well, I think it is, or not on your PowerPoint, but it may be on your packet. I'm not 100% sure yet. But you have, this is just an illustration to kind of depict what the renal threshold is. Okay. When it comes to renal threshold, you guys have to know this definition. Please write it down. Renal threshold is a maximum amount of a substance that is reabsorbed back into the body from the kidney tubule. So it says the maximum that is reabsorbed back into the body. So where does that occur?
In the tube.
The proximal convoluted tubule. Yeah, that's right. The maximum reabsorption. Remember I talked about that? Okay, so that's what that is. And let me explain that a little bit more in detail. If we have the afferent arteriole coming in, right? And infiltration occurs and it's giving off all the particles along with water. It's coming back down. Notice how right here it says 180 liters per day. That's how much fluid is being reabsorbed. That's the renal threshold. That's what it's defined as. As you get down to the loop of Henle, it says 36 liters a day. That's a lot still, but it's not 180. Okay, right here, 36 liters a day get reabsorbed, 24 liters a day on the ascending loop of Henle. Okay, and then once you get to the collecting ducts, only 1 liter a day. That's why the diuretics, folks, that work further out on the nephron, it's not that effective, such as like the mannitol, the osmotic diuretics, because overall in a day you're only retaining 1 liter. So even if it's blocking the reabsorption of this one, it's only got 1 liter to work with. However, if you work on the loop of Henle, it's 36 liters per day. You have a lot more fluids. The reason why we don't have medications that really act on this particular area, because this renal threshold, the maximum reabsorption, we need those fluids. This is like the baseline of fluid that our body needs in order for it to function. So we don't really have diuretics that work on this particular area. Okay. However, we do have the loop of Henle, which are the most powerful ones that we have. Any questions on that? Okay, please know this term, folks. All right, let's talk about dehydration a little bit. When a patient is not being hydrated adequately, either due to inadequate fluid intake or some other underlying condition, okay, that's what it is. Urine will be dark, amber color. Specific gravity tends to be slightly elevated as well. And you would understand why. We just talked about that. The gravity, the particles are elevated because it's highly concentrated, meaning the gap between particles and fluid is very small. Okay, so it looks really dark like this. Please write this down, folks. Oh, come on. It should be a better song, too. Does the whole dehydration concept make sense, folks? Why it would be darker? Why it would be amber like this particular color? You don't have that fluid to dilute to make the specific gravity a little bit low. You folks know what the average specific gravity of urine is? It's 1.003 to 1.035. You have to know that value. Okay? For 1.003 to 1.035. Anything in between, folks, is normal. Okay, if I tell you my patient has a specific gravity of 1.027, that's normal, because it could go all the way up to 1.035. All right, and then if I tell you a patient's dehydrated, the specific gravity will be slightly elevated, such as a little bit above 1.035. Pardon me? Specific gravity? Is that what?
Is SG, what is it again?
I always just put specific gravity.
Just put the initials are SG.
And at the hospitals, yeah. At the hospitals,
Faster
yeah.
to write it.
Pardon me?
It's faster to write it.
Yeah, I know, right? Just be able to recognize it. On the exam, it's gonna spell it out the whole. It's gonna spell out the whole word. You just have to know the values. What does it mean if it's high? If it's, I'll give you a scenario, folks. Like the patient came in, we did all these lab values to the patient, all these vital signs. This is what they are. So you tell me what's happening with the patient. Depending, you'll look at, mind you, folks, we're testing you on renal disease, right? On the renal system. So keep in mind that it's probably going to be something related to kidney function. So blood pressure, gravity, osmolality, how much urine output. What's the average urine output in an hour for an individual?
30.
Yeah, as little as 30, okay? From 30 to 50 mLs an hour, that's pretty normal. So please keep that in mind. May I switch the slide? All right, let's go now to urinary retention. You folks see his bladder? His bladder is so distended, okay? It looks like he's pregnant. When the bladder, folks, is not distended, how do you palpate for it during your assessment? Yeah, you go to the suprapubic area, right, and you start palpating. It's supposed to be at level with the suprapubic area if it's empty. However, as it gets full, it keeps going up higher and higher, and that's very high because it's not even it's the umbilical point is pretty high, but it's about almost a little bit more than halfway there. What do you think is causing urinary retention on this patient? It could be a lot of different issues. Yeah, it could be prostate, it could be some type of stricture. Okay, is the stricture though before the bladder or after the bladder?
Before the bladder.
Where is it at?
Before the bladder.
No, guys, it's after the bladder because the bladder's full. If it were before the bladder, it would be the ureters are up and the bladder wouldn't get any fluid. Does that make sense? Okay, so yeah, it's after the bladder or at the bladder. All right, so urinary retention, the inability to void despite the urge to void. So the patient feels like they have to go. A lot of different elements can cause this patient to go under distress. When they have a tendency to urinate, or when you guys have a tendency to urinate, how do you feel? Oh my God, I gotta go. My wife had an ultrasound. Oh, I'm having a girl, by the way.
I told you.
I know, like, oh. Yeah, I mean, I'm happy about it. Anyway, what was I saying? Yeah, my wife had to drink a lot of fluids because you want to visualize the baby better, and so she goes, I gotta pee. Man, you have your womb, your uterus that's pressing on the bladder as well. So you guys know how that feels. What do you think happens to the blood pressure?
Goes up.
Yeah, blood pressure goes up. You become tachycardic. You can even become a little bit diaphoretic. So keep all these elements in mind, folks. You'll have a distended bladder. The way you feel it is by palpation, folks, at the pubic symphysis, and you keep working your way up, depending on where it's at. The patient will have discomfort in pelvic region, okay, meaning any type of pressure is very sensitive for the patient. This is very classic. They're voiding frequently. They're always going, but the problem is they're not going a lot. Okay, very small amounts. It may cause something called uremia. Please write that down. That's too much ammonia levels in the bloodstream. I'm sorry, it's too much ammonia. It's an element of ammonia inside the bloodstream. That's right. So please understand, folks, if somebody has some type of urinary retention, it may cause uremia. What do you think the urine looks like for this individual when it comes to the clarity?
It's amber.
It's amber, it's concentrated, highly concentrated, because all the sediments, all the elements that are supposed to be filtered out are staying inside along with fluid, but they usually settle down at the base. So when you actually urinate, it's highly concentrated. Sometimes, folks, it has a foul odor smell. What does that usually mean? Usually means a potential UTI, yeah. Understand that urinary retention, folks, can also lead to UTIs. That's important for you guys to know. Urinary retention can also lead to UTIs. Alright, so when it comes to medical management for urinary retention, you can do a warm shower or sitz bath. That's okay, but that's not something that's too often used. Natural voiding position is possible. If you're a male, have the male stand up on the toilet and really try to go. You can even turn on the faucet, turn on the shower head. Those elements do where they stimulate the patient to actually want to micturate. If it's female, you have her sit her down, try to have her go. You can place a urinary catheter, but understand that anytime you place a urinary catheter, you have the risk of infection. That's very important for you guys to know. Okay, anytime you have any scenario, okay, if all the elements of the scenario look decent, look good, if the patient's blood pressure is good, the output's good, anytime, or if the patient has no high fever, no medications, anytime they have any type of invasive procedure such as a catheter, they run the risk of infection. We can perform a surgical removal of the obstruction as well. If there's any type of stricture or stones inside the urethra, let's say, we can do that as well. We give them analgesics to help them out with the pain as well. May I switch the slide? Alright. Urinary incontinence, folks, is something you guys have to know. If I say I have urinary continence, what does that mean? No. Urinary continence. Continence means I can control it, right? I can control it. At what age does an individual, at what age can we actually start controlling? Are we anatomically old enough to control our voiding?
2.
Yeah, usually at 24 months. That's also really important for you guys to know. Yeah, at what age do we stop or do we lose our control?
Older age?
Usually the first time you get drunk at night. So I told you guys about my cousin, right?
Yeah.
Oh, my cousin, every time he gets drunk,
Yeah.
I just feel something warm. Oh my God. It happened once, but I'll use it like it always happens. So look, when it comes to urine incontinence, meaning we have no control over voiding. We have no control over it. Okay, meaning it comes out before when we don't want it to. Total incontinence, meaning you have no control whatsoever. You have dribbling, meaning it kind of comes out a little bit, dribble, just a little bit. And then you have something called stress incontinence. You folks know what stress incontinence is? This is going to be on the test. If I cough, sneeze, and I micturate, that's stress incontinence. Anytime my body is put under stress, not psychological stress, meaning sneezing, bearing down, or coughing, you're putting pressure on your bladder, you don't have that good control of it, so you micturate, you actually urinate a little bit. That's stress incontinence. You folks know what urge incontinence is? Yeah, like this constant feeling that you have to go. Patients that have some type of obstruction or urinary retention may feel that. Also, patients that have some type of UTI. It can be secondary to infection. If somebody has a UTI, they have a hard time controlling their voiding ability. Loss of sphincter control because of, let's say, a woman just gave birth and the pelvic muscles are very weak. When it comes to the sphincters, folks, they're muscles. So when a woman gives birth, they stretch out those muscles and they don't have as much control anymore. So that could actually lead to incontinence as well.
The stress one, right?
Pardon me?
The stress one? If you have kids.
Oh, that you develop, yeah, you
Girls
develop.
Like sneeze and then.
Yeah, that's true. I was gonna say that, but I thought I was like, no, I'm not gonna say that. But yeah, that's true though. It's true, but I don't know for how long. How long does it happen for? Forever? Yeah, usually though.
Forever, right?
Usually it's never the same. It's never the same. However, what can you do, guys, to improve the control?
Don't have kids.
Pelvic. That's the answer. Kegel or pelvic floor exercises. Please write that down. Kegel or pelvic floor exercises. How do you do that? You get a big old weight and you. What you do, folks, is you know every time you guys go to the restroom and if you pee, you push you hold you push down. Like I'm doing it right now. I'm doing Kegel exercise, and then if you want to stop the voiding, you hold it. That's what I'm doing right now. So contraction and relaxation. Those are Kegel exercises, folks. That'll help you with the control of your pelvic muscles. So again, they're called Kegel exercises or pelvic floor muscle exercises. All right, also sudden change in pressure in the abdomen. And that deals with postpartum as well. You've been used to and accustomed to this huge uterus carrying this baby, and suddenly you give birth, the pressure inside changes as well. Okay, or you have removal of a certain organ, that might influence it as well. It can be permanent or it can be temporary. I want you guys to know, I talked about the difference between stress and urge incontinence. This type of urinary incontinence, any type of urinary incontinence may happen if you have a surgical procedure, and that's not what this talks about. It says it happens often with the elderly due to lack of pelvic muscles. You have to know that as well. However, though, if I'm going to go into the hospital, I'm going to have an abdominal surgical procedure. We have nerve endings that feed our bladder that send the message to our brain that, hey, our bladder's full. Those same type of nerves in that area let us control voiding. So if I had a laparoscopic procedure or an open abdominal pelvic surgical procedure, it's very common that you nick or you cut one of those nerves. If that happens, you may develop some type of incontinence because of that. It's called neurogenic bladder. I'll talk about that in a little bit. But what happens to the elderly, folks? Yeah, due to the lack of pelvic floor muscles, they lose the ability to void, or they develop incontinence. It's very common.
Did you say what age?
Pardon?
Did you say at
The
what age?
older adults, defined by 65 or older. Yeah, defined by 65 or older. May I switch a slide? Yes. All right, so of course, clinical manifestations include involuntary loss of urine, leaking with coughing, sneezing, or lifting. That's stress incontinence. That's stress incontinence. Okay, medical management, you want to treat the underlying cause, surgical repair of bladder. However, the important stuff is temporary or permanent catheter. That's usually going to take care of it. But again, if we introduce a catheter, what's the patient at risk for?
Infection.
Always infection, okay? Bladder training. This is actually really important for you guys to understand. If I have a catheter, right, because I had incontinence or I was in an accident or whatever, I had a catheter placed inside of me. This catheter has been collecting urine for me, meaning I haven't been voiding and I haven't been practicing my Kegel exercises, right, because it's been just draining everything out of me. What happens once that catheter is taken out? If it's been inside of me for a month?
You lose the ability to control.
I lose the ability to control. So while I'm building up my strength again, I'm urinating all over the place. So we can do something called bladder training. The doctor's going to have an order for DC or discontinuation of the urinary catheter, right? For a few days before that, what you do is every so often you clamp it. You clamp the urinary catheter for 30 minutes, and you let the bladder get full. That's how you start bladder training. You allow the bladder to get full, so you get that sensation back. Oh, I'm getting used to it, and then naturally your sphincters start contracting. You start contracting and using them, and that's called bladder training. Okay, guys. Anytime you do bladder training, you got to make sure that once you clamp the catheter, you do it for 30 minutes, and you come back and you unclamp it. Okay.
Same
No
thing
joke.
with the kids also.
Same thing.
Diaper.
That's right, and I'll get to that right now. Yeah, I'll get to that right now. So, guys, please know that if you're gonna do bladder exercises or bladder training exercises for a patient who's had a catheter or who has a catheter, don't forget to unclamp it after 30 minutes. Okay? I'm just telling you because it's happened. Never to me, but it's happened. Also, bladder training exercises is taking the individual and having them sit down or stand up, assume their natural voiding position, so they can. That's bladder training as well, and that's what we do with children as well. Okay, and again, Kegel exercises or pelvic floor muscle exercises is something that we can recommend. And I'm going to test you on those elements, folks. So please know that. And at what age is a baby physically mature? At 24 months. Good. That's what we start. If you guys look at the developmental at the developmental chapter, it talks about you can start potty training at 24 because at that age they're physically mature enough to actually do it. My daughter just peed and pooped by herself, and she sat down. It was a big old poop too. My kids poop a lot. My sons though, like that. Oh my God, son. All right, I spoke about neurogenic bladder. What's neurogenic bladder?
When they nick a nerve.
Yeah, when they nick a nerve. That's correct. When we destroy some type of nerve passageway. So loss of voluntary voiding control is what's going to happen. Results in urinary retention or incontinence. It depends which nerve is nicked. We're not going to be here discussing which one. However, we do know what happens though. You could either be incontinent, you have no control, or you can't void, hence you retain the urine. Lesion of the nervous system that interferes with normal nerve conduction to the urinary bladder may be caused by abdominal or pelvic surgery. That's very important for you guys to know. Okay, anytime you have some type of abdominal or pelvic surgery, you run the risk of actually severing that nerve, which may lead to something called neurogenic bladder. It's called neurogenic bladder. There's two types. It's called one's spastic and one's flaccid. Spastic is going to be when you have no control, but every once in a while when your bladder gets sufficiently amount of full, it starts firing off the nerves and you start micturating, but then you start holding it as well. So it's spastic. It kind of, you dribble a little bit, then you stop, and you dribble. You have no real control over it. Flaccid, meaning you have no control over it, and it just keeps coming out. You become completely incontinent. Please be able to identify those two. Please be able to identify what type of issues may lead, or what type of elements may lead to neurogenic bladder. And what did I say may lead to neurogenic bladder? Abdominal or pelvic surgery. I won't change it. I won't change it.
Sorry.
Yes.
So you said that flaccid is
Flaccid?
dribble and stop?
No. Flaccid is, think of flaccid, like no tone to it. So when it comes to your sphincter, it's open all the time because it's flaccid, it's weak, it's loose. So the sphincter is loose, hence the urine's just coming out. When it's spastic, think of spazzing. Think of the muscle spazzing. So you're dribbling sometimes, you're urinating sometimes, but then you stop. So you have no real control over it. Which one of those two is more likely to lead to urinary retention? Based on what I just explained to you. Spastic. Okay. What happens, folks, when a patient becomes incontinent? What are they at risk for?
Infection.
Infection? Why? Okay. What else?
CNAs don't change temperature.
Because the CNA. Yeah, because skin integrity, folks. Skin integrity, that's why. May I switch the slide? Yes? Alright. Clinical manifestations included infrequent voiding, incontinence, diaphoresis, flushing, nausea prior to reflex incontinence. Medical management includes antibiotics, uricoline. Now, uricoline is, you guys have heard of anticholinergics that stop the secretions and stop the motility of certain elements? Well, uricoline is the opposite. It's a cholinergic. And it actually, it makes you secrete more, so it helps you void. It helps you have more control over that sphincter. At least that's the attempt. Intermittent catheterization. You folks know what intermittent catheterization is?
Straight cap?
Yeah. But what it's
In and out.
yeah, in and out, in and out. When a patient may have neurogenic bladder or some type of incontinence, and they may be retaining urine, let's say. And again, some of these patients, they can do everything themselves, except sometimes they're paralyzed from the waist down, and they have neurogenic bladder. They have no control over it. So they give them several catheters, and they actually catheterize themselves. So intermittent catheterization substitutes voiding. So that when you actually perform intermittent catheterization, it limits the likelihood of you developing some type of retention, which decreases a UTI possibility. However, every time you catheterize somebody, what do you run the risk for? Infection. So make sure you do it right. Yes?
So they can still feel that they need to go, so it's not some people.
No, they don't. It depends on like if they're like paraplegic, let's say. Actually, yeah, if they're paraplegics, if they're paralyzed from the waist down. A lot of the times, depending on where that nerve damage was, they have no sensation. So they know that like clockwork, every 2 hours they go and catheterize themselves. You folks remember what a cock pouch is? It's an ileostomy, okay, but it's got a reservoir right behind the abdominal wall, but it's really tight when it comes out the skin. So it's a continent ileostomy, meaning you have control over it. It's the same thing. You do intermittent catheterization of that cock pouch. So you put the catheter inside every couple hours, and you get the fluid out, the liquid stool, and so it's kind of the same thing. And again, folks, bladder training. Bladder training works a lot. There have been a lot of cases in where the patient's paraplegic, and they've been paraplegic for a long time, and they keep doing bladder training, and they keep training them, and eventually they actually gain control of the voiding just when they sit down, but they can actually do that instead of catheterizing themselves. May I switch the slide? Yeah. All right, UTIs. UTIs are very common, folks. Very common, especially in what population? The women. The women. Why the women?
Because
Easy access.
The urethra. Yeah, easy access. That's right. The urethra. She looks at them all crazy. Yeah, easy access. So the female urethra is no longer than 3 inches. Okay. The male urethra is how long? Okay, it's about 8 to 12 inches. It just really depends on the individual. But however, if I'm urinating, okay, what am I pushing out? Waste product. So by the time that the bacteria gets to the part of the urethra and it causes the infection, usually a male, since the urethra is longer, we have the ability to actually urinate it out. However, for a female, since it's really short, it just goes in there and it may make itself comfortable and cause an infection. So yeah, women are more susceptible to UTIs. What can you tell a woman to do to prevent UTIs? How do you clean? From front to back. You clean from front to back. What else? After they finish intercourse, folks. Oh, that's true. Yeah, that's that. Wow. Okay. Yeah, you want to manage your glucose levels if you're diabetic. Also, if a female's after intercourse, folks, urinate, to pee, to flush it all out. All right, so let's talk about UTIs, folks. Shh. Types depend on location, of course. We have UTIs that are in the urethra. We have UTIs that are in the bladder. We have UTIs that are in the ureters. We have UTIs that are in the kidneys, pyelonephritis, and we'll get to that next week. Remember, urine pH is mildly acidic, usually from 4.6 to 6 point something. Okay? Please make sure you guys know that. It's slightly acidic.
4.6 to what?
Just know that it's slightly acidic. That's what you have to know. Just know it's slightly acidic. I think it's in the book. If it's in the book, then great. Just know that it's slightly acidic. So if the average is 7.35 to 7.45, talking about in the 6s. Okay, that's slightly acidic. Pathogens enter the urinary tract, meaning bacteria goes inside. It causes an infection. Usually, folks, the most common type of UTIs that we find at the hospital are nosocomial UTIs, meaning the patient comes in with a fractured hip. We put a catheter inside, we don't do it correctly, and they develop a UTI. That's nosocomial. The insurance will not pay for that. The hospital pays for it. And some hospitals, that they have too many nosocomial infections, they'll be closed down. Bladder obstruction. Remember I spoke about this before? If a patient has a bladder obstruction, you have the concentration of urine. The concentration of urine inside the bladder, but also you're not getting rid of the pathogens inside the urethra because you're not urinating. Insufficient bladder emptying. If a patient is at high risk for a UTI if they are continuously not voiding, that usually puts a patient in a high risk for developing a UTI. Decreased bactericidal secretions of the prostate. If you guys are wondering what the prostate does, aside from hormone regulation, it secretes these enzymes that actually keep the bacteria at bay. Okay, so if you have issues with the prostate gland, that can lead to a UTI as well. Perineal soiling in females, meaning if the patient has a brief on, okay, or if they're in bed and they're dependent on you completely, and they void or they defecate and you don't clean them up, that can lead to a UTI as well. And of course, sexual intercourse. So for the perineal soiling, what do you provide? What do you teach the female to do?
Like from front to back.
Front to back. For the sexual intercourse, what do you teach the female to do? To urinate afterwards. Yeah, that's right. How's the pH? How's the urine pH? Slightly acidic. All right, good. No other questions? All right, clinical manifestations. These are very common. Please know them. Urgency. Okay, they feel like they gotta go. They gotta go. They gotta go right now. Frequency, burning on urination. The patient has several trips to the restroom, folks. They sit down or they stand up and they urinate, and they feel like they have to urinate so bad, and then they finally urinate, but they only urinate a little bit, and they feel it's burning, and they feel like it's inadequate emptying of the urinary urethra, and they go back to the bedroom or wherever they're going, and then they feel like they gotta go again. That's what it talks about by urgency and frequency. Nocturia. Okay, nocturia. What's that?
In the night?
Yeah, usually in the night. It doesn't mean you wet your bed. It just means that you have to go at night. That you have to go. Normally we can all hold our bladder or hold our pee until the morning. Remember to offer a bedpan frequently to a patient who is on bed rest or an elderly patient who is at risk for a fall. Okay, if they're confined to a bed or something, and if they are older, they have probably nocturia because remember the pelvic floor muscles are weakened. So you want to remember to offer a bedpan frequently. Does that make sense? To prevent them soiling themselves and increasing the likelihood of developing a UTI, skin breakdown, and all those other elements. They might have abdominal discomfort, perineal. Make sure when it comes to the perineal. Oh no, excuse me. Abdominal discomfort. It could be perineal, and especially a heaviness in the perineum, or back pain. Why would they have back pain? Yeah, the kidneys. The urine, if they do have a UTI, please be able to distinguish it from your regular urine. It's going to be cloudy. It's going to be blood tinged sometimes. Okay, sometimes it's blood tinged. Okay, so that's what it looks like if you have a UTI. When it comes to diagnostic tests, folks, for UTIs, we do a UA, CNS. You folks know what that is? Write this down. UA stands for urinalysis, which was on a couple of slides before this. And CNS stands for culture and sensitivity. So they get the urine, they culture it, they grow it, they see what type of bacteria is growing, and they see what medications or what antibiotics are actually killing it. And then that's how they know that we can give you this antibiotic. That's UA-CNS, okay? And to do a urinalysis, you'll need about 10 mLs of urine. You guys ever seen the little vials? Okay, little vials are color-coded, and it's for UA, for urinalysis. You need about 10 milliliters. So please know that. Write that down.
What is CNS again?
Culture and sensitivity. We culture, meaning we take the urine and we grow it in a lab, in other words, and it takes like a few days. And we see what type of bacteria grows from that urine. That's the culture, so that we can identify the bacteria, what it is. And the sensitivity is we put different antibiotics on it to see which one actually kills it. And that's how we know that, oh, this erythromycin works. So I'm going to give Leo erythromycin for your UTI. Okay. When it comes to the female, and the female giving us a sample of urine, you have to make sure that you clean the meatus and separate the labia. Okay, you got to separate the labia while voiding. Okay? Why you look so confused? Do you understand why I'm saying that though? Okay. Usually if the labia is closed, what happens to the urine once it comes out? It gets contaminated with the labia. So you want to make sure that you clean the labia first. They have antimicrobial pads that they give you to cleanse with first, and you cleanse from front to back. And then when the woman urinates, you have to make sure that the labia is open so it won't come in contact with any of the skin, so it won't bring along any of that bacteria. Because the bacteria we're trying to find is supposed to be inside of our body. So if it touches a labia, if it touches any other part, it might carry on the bacteria with it. Any questions so far? You guys got all this down? It's important stuff. All right, medical management, of course, antibiotics, urinary antiseptics, and analgesics as well, because it can be very painful. You want to encourage fluids. That's very important. You want to encourage fluids to flush everything out. What type of juice can you give? Cranberry juice. Actually, it's very effective. It's highly acidic. Usually bacteria doesn't do well in highly acidic areas, so if you keep drinking acids, it concentrates your urine to be a little bit more acidic. And the urine is acidic as it is, right? So you keep it nice and acidic, you reduce the likelihood of you developing a bacterial infection. And of course, perineal care Front to back. Man, switch to slide. Yes. Urinary obstructions. We're almost done, guys. We're almost done. Any type of stricture, kinks, cysts, tumors, calculi. What's calculi? Stones. Not necessarily kidney stones, just anywhere. It could be in the ureter. It could be in the bladder. It could be anywhere. It could be in the urethra. Usually, this is how you know. A male's peeing, and while they're urinating, the pee comes out and it goes this way. It goes two different ways because there's usually a stone right in between, and it sends the urine out to. I've seen that once on a patient, on an older patient, and his stone was right at the tip of the meatus, but inside the urethra. And so when he urinated, the flow was all scattered everywhere but straight. And then he was uncircumcised, so he thought it was the foreskin, and he would pull it back, and it was still just going everywhere because he had a stone inside the urethra. So that's what calculi is. It could be renal calculi, urethral calculi, ureter calculi. Please know the difference between your ureters and your urethra. Don't get confused with those two. Prostate hypertrophy as well, meaning the prostate gland gets enlarged and it blocks off the outflow of the urine. When it comes to clinical manifestations, guys, continuous need to avoid. They feel like they always have to go. They void again in small amounts frequently. It's probably concentrated. They'll have pain and they'll also have nausea. May I switch the slide? When it comes to medical management, folks, we'll always do a catheter, okay, if the doctor orders it. Suprapubic cystostomy. Again, that's with the bag. Suprapubic catheter is what you guys see right there. That looks nice, though. It usually doesn't look that nice. It looks really bad. Okay? Yeah, I know. Okay, ureterostomy, meaning we go through a surgical procedure, we access the ureter, and that's how we hook it up to a tube that actually drains the urine from there. We usually do that if the bladder or the external genitalia is damaged. A nephrostomy. This is an opening going straight to the kidney, usually to the renal pelvis, and it's collecting urine from there as well. Basket extraction. You folks ever hear of a basket extraction? This is somebody who develops a lot of stones. I'll show you an illustration. Let me show you an illustration. Anyway, pain relief, narcotics, anticholinergics. So this is what it is. Imagine that being the ureter. So they put this, it's called a basket extraction device. They put this inside the ureter, it's very small. And this right here, it captures all the stones. So they leave it there for a predetermined amount of time. After they caught all the stones, they bring it out. Okay? Mind you, guys, how big is the ureter? It's very small, and look how small. I mean, that fits in the ureter. It's really small. It's really, really tiny. And when you're putting it in there, folks, it actually, even though it's like this, it collapses within itself while you're pushing it through a very small lumen. And then once you get to a more patent lumen, it opens up a little bit according to the surroundings. So don't think it's like so traumatic. Oh, and when it comes to the basket extraction, after the basket extraction, folks, this is very commonly performed. Make sure you're familiar with basket extraction. You want to always measure the urine output to make sure that there's no type of blockage. So you want to make sure that you measure the urine output. Any questions? That's it, guys. That's it. Go home. Nah, just kidding. Go on a break, guys. Come back at 10:45. Any questions? No?